Hey, hi all. Good afternoon. Am I audible?
Yes.
So, can we start now? Hello. Am I audible?
Yes.
Good afternoon, all. First of all, I would like welcome you all of for the next session, and I'm welcoming Mr. Kamlakar sir again. Sir, thank you to be with us. I'm handing over to Anusha ma'am to continue the session.
Good morning, everyone. So this is Anusha. Today you are first for this session. So previous continues of previous session, management of GI symptoms by Dr. Kamalakar Garu. Welcome, sir. Sir, are you there?
Yeah, I'm here. I'm here. Right. In a minute. Am I audible?
Yes, sir.
Right. Just a minute. Yeah. Is
Clear
it
now.
okay? Right, right. Okay. So, welcome back to another session. This is actually the continuation of the session last time we had, the management of gastrointestinal symptoms in palliative care. And it was about last time nausea, vomiting, and constipation we dealt with. Today, though it is a short topic, but it is very important potential topic. It is a continuation to last topic. Yeah. Hope I'm audible to everyone. Right. In case you have any questions during this session, you can raise your hand and then unmute and you can speak. Okay. Right. Let us start the session. Yeah. So the same question last time we had about vomiting and nausea. The same question. Have you ever cared for a patient who stopped passing stool and kept vomiting? It looks like they're very common symptoms. Stopped passing stool can be constipation, we all know, and then vomiting, we know about it. But imagine a patient is kept on doing this for days. The patient is not passing stool at all, and then continuously vomiting. Then, in palliative care especially, we have to suspect something called bowel obstruction. Today we are going to deal with this actually. In palliative care, bowel obstruction is one of the most distressing symptom we deal with. Imagine a patient is not taking anything orally and kept on vomiting and then not passing stool at all. You can imagine how distressful symptom that is. So, in case in future you are going to become a palliative care nurse, you are going to see such patients. Once there is a patient in your, under your care, then how are you going to care that patient? That is what we are going to deal today. So, I want to ask a question. What is bowel? What is called bowel? If anyone wants to answer one or two, please unmute yourself and let us know what is bowel.
Intestine.
Excellent, excellent. Yeah, and it also has large and small intestine. Yeah, good. And obstruction, it is as simple as it is bowel. We know it
Okay.
is intestine, either small intestine or large intestine. And obstruction is something obstructing this small intestine or large intestine, small bowel or large bowel. So obstruction sometimes may be internally, maybe externally. What is the function of the bowel is to move the content forward, and then while it is moving forward, the function is to absorb the nutrients, right? Then when there is constipation, then the function is totally compromised, and the function is compromised for a long time, then the patient is going to develop impaction and then obstruction. Yeah. Right. What are the signs and symptoms of this bowel obstruction? Try and mention.
Due to abdominal distension.
Right. Excellent. Yeah.
और
Any go
अगर
ahead.
अगर मोशन पास नहीं होगा तो गैस अगर गैस पास नहीं होगी तो एपिगैस्ट्रिक पेन कॉज हो सकता है.
Excellent. I should appreciate for your, that imagination really. When there is based on the location, the patient develop typical pain. Okay. So as you rightly mentioned, because of the distension, patient, that stomach distension would cause more discomfort. In turn, regurgitation, as you mentioned, typical colic pain happens. Okay. Yeah. Now, nausea and vomiting the same way. When there is obstruction and all the accumulation is happening and happening, and then at one point more regurgitation happens. Yeah. And when nausea and vomiting is there, patients usually mention you, they feel like it is like a fecal matter, typical fecal matter, that fecal smell they have, because they're supposed to pass the stool from the rectum. But now it is not going forward. Once this obstruction happened, absolutely, what happened then? Accumulation happens, all the fecal matter which was precipitated on the, above this obstruction, end of the day, will be regurgitated back through mouth. How undignified. Cramping abdominal pain, as we discussed, and swollen belly, the distension will be there. No stool or flatus. Patient, when you ask the patient, we will go through the assessment. There is one assessment cue you need to know, I'll tell you. No stool or no flatus at all, totally 100%, then that is absolute constipation. And then gurgling or absent bowel sounds. And this is actually when you go, listen with this stethoscope, where are you keeping it exactly through the bell and the other side. When total bowel sounds are absent, you can, confidently say that that is absolute bowel obstruction. Now, our role, the nurse's role in assessment, you need to pay attention especially on the assessment, because you are the bridge from the patient to the doctor. When I am there, I may not be able to spend some time with my patient. You're always there with the patient round the clock. You know many things better than me. That's the reason my attention more on the assessment, even in the nausea vomiting also, and even in this session also. Medical management, definitely you also need to know, but to the point where what medicine works for what. Okay. But moreover, your attention most of the times to be on assessment. So now in the assessment, first and foremost, the bowel history. Just like in constipation, as a topic we have learned, ask and observe. You have to ask and observe the patient, the below things. Simple. When did the patient, last pass stool or gas? कितने दिन हो गया पेशेंट को पायखाना पास करके और गैस भी पास करके. And complete absence of stool and flatus may indicate a complete bowel obstruction. अगर पेशेंट से पूछे जाए तो पेशेंट ने आपसे बता रहा है कि मैडम सर, मैं लगभग एक हफ्ता से पायखाना पास नहीं कर पा रहा हूँ और गैस भी नहीं जा रहा है, मुझे बहुत उल्टी मतली पता चल रहा है. Then it is almost 1 week. There is no, passage of stool and gas. That is absolute obstruction. अगर पेशेंट ने आपसे बता रहा है, मैडम आई एम एबल टू पास एटलीस्ट some gas, I feel that, and also little amount of stool I pass. That means that is partial obstruction. So, yeah. What was the nature of the last stool? Nature, that means last time जब patient ने motion pass किया है, nature, how was it actually? Hard है, loose है, green color है या red color है, all those things you need to document. Hard and dry stools may indicate constipation and impaction. Loose or ribbon-like stools could suggest partial obstruction. And foul-smelling, mucus-laden stools may occur in malignancy. Now, vomiting, the other symptom. So, how often is the patient vomiting? Frequency of vomiting, and that suggests the obstruction where it is actually. It is very frequent, maybe small bowel. And then it takes some time, maybe as the time you take some food, जो खाना वहाँ large bowel तक जाएगा, लगभग 1-2 घंटा लगेगा. Then patient vomits. Then it is, with the assessment itself, you will have an idea, tentative idea, not absolute idea, but you can guess that पेशेंट ने खाना खाया 1-2 घंटे के बाद वॉमिटिंग और उल्टी ये किया है, मतलब समवेयर इन दी डाउन द ऑब्स्ट्रक्शन, मे बी इन द लार्ज बबल, समवेयर इन द कोलन, मे बी पेशेंट ने अभी खाना खाया तुरंत उल्टी करने लगा, मतलब समवेयर इन द अपर साइड, अपर जीआई ट्रैक्ट, so immediately they vomit. As you all know, greenish, it is usually bilious bile, mixed vomiting, often indicates obstruction below the stomach. The fecal smell or coffee ground vomit suggests severe obstruction. And coffee brown in the sense that is kind of, the iron is digested in the blood, and that is usually presented as brown color or dark, sometimes black color also. That can indicate GI bleeding. So what you need to pay attention? See, it is a clear assessment. When you talk to the patient, you go back, you are asking about the bowel history and all those things you will document, and you go to vomiting and you document all those things. Why that is very much important? When you mention, sir, ये जो patient vomiting कर रहा है and the color ऐसा है, then I'll immediately understand that maybe some internal bleeding is happening. Maybe my clinical judgment and the way I prescribe medicine would change. End of the day, you and me together going to provide some comfort to this patient. Pain assessment. Yeah. Look at this. Is the pain is crampy, sharp, or continuous? I'm sure in the pain class, you must have gone through that PQRST scale, right? That is the mantra for the nurses. You need to keep that in the mind and practice every time. The crampy pain comes and goes, usually mechanical obstruction. Why? When there is a peristaltic movement, whenever there is a movement, then the patient has the pain. When there is less movement, no pain. Continuous pain may suggest strangulation or ischemia. Colicky pain plus distension, common in bowel obstruction. So how to assess this pain? Usually assess using pain, you have different scales, but this numerical rating scale, you can ask the patient. In case patient is unable to understand, there are many ways to assess pain. Patient say, मैं कभी कभार आई यूजुअली पेशेंट से पूछे जाता हूँ, 1 रुपये में आपका दर्द कितना हो सकता है, इस वक्त कितना फील कर रहा है अपने दर्द, नहीं तो पेशेंट इज इन स्टिल नॉट कंफ्यूज स्टेट, आई यूजुअली आस्क आपका दर्द इतना है और इतना है और ज़्यादा है. That you will be able to understand the severity of the pain. Some patient may not be able to express it to you, but they'll be able to tell you when you ask. Based on that, our clinical judgment happens. Then abdominal sounds through the, you can auscultate with the stethoscope by using the stethoscope in all the four quadrants. You know the four quadrants of the abdomen, right? You all know, right? Four quadrants. We divide the abdomen into four areas,
area. Yes, sir.
right?
Right?
Very good. Keep that in the
Keep
mind.
that in.
Based on the area, for example, right upper quadrant में दर्द है उनको. Then you can, imagine that what are the organs in the right upper quadrant. Maybe there is a liver and gallbladder. You may be suspecting, then you immediately ask the patient, अगर उनको उल्टी आ रहा है तो कौन सा कलर में आ रहा है. अगर आपका इमेजिनेशन के साथ पेशेंट ने जो भी बताया मतलब ग्रीन में आ रहा है तो then you are clear that maybe there is some obstruction, right? Down the stomach, gallstones may be obstructed. So every single question in the end of the day will give you clear cut picture. Now, when you hear there are high pitched sounds, these days in YouTube's, you get to hear even these sounds also. You can type, go through YouTube and type what is high pitch sound and no sound, all those things, just for your understanding and experience. There is high pitch sound and, tinkling sounds. That is classic for early mechanical obstruction. And no sounds, totally silent abdomen, that suggests you that paralytic ileus. There is no movement. There is a paralysis of the ileus. Can lead to advanced obstruction. And then gurgling sounds, rushing sounds. So maybe normal, and that indicates hyperactivity of the bowel. Okay? Then you have to listen for at least 1 or 2 minutes before declaring the bowel silent. Yeah. Apart from that, you will see the patient's general condition, overall well-being, how are they doing. Look at their hydration status, how the patient is presented to you. Totally पूरा शरीर dry दिख रहा है आपको, mouth and dry lips दिख रहा है, and then patient का urine outflow बहुत कम है पूछे जाए तो, and then low BP है. It all suggests patient is totally dehydrated. Why dehydrated? Then you should ask the other questions, supportive questions. मतलब patient को vomiting वगैरह है क्या? Maybe the patient has vomiting. एंड देन पूर ओरल इंटेक, जब वॉमिटिंग है ओरल इंटेक बहुत कम हो जाएगा, पेशेंट विल नॉट बी एबल टू टेक. एंड इज द पेशेंट ईटिंग और ओनली सिपिंग वाटर, and decreased intake may worsen weakness also. In palliative care, I don't know in the other class whether it is mentioned or not, you need to check the patient's overall health by using some scales. You know about ECOG? Otherwise, we usually in our setup we use something called PPS, palliative performance score or scale. It is usually somewhere 0 to 100%. Now we people are very healthy, walking, talking, taking food, and working. Maybe our status palliative performance score somewhere 90 to 100%. इमेजिन एक पेशेंट वॉकिंग में दिक्कत है, खाना नहीं खा पा रहे हैं, उनका स्टेटस समवेयर में बी 60 or 50%. You need to know that also. Then when you are assessing this patient, you should mention उनका performance score कितना है, 10% या 20, 30, 50. It is available. Yeah. And also overall check patient's vitals regularly, BP, pulse, and it is not very mandatory in palliative case setup, but when a patient is presented, at least you need to check at once, and then whether they are improving or not, you will be able to understand. Coming to the pharmacological management. What are the most common medicine we use in palliative care for this bowel obstruction? And even nurses also, you should understand what medicine, which route, and how we are giving. Look at this, symptom-based medication. Here we are not correcting the bowel obstruction. We are not correcting the mechanical obstruction. We are not correcting the malignant bowel obstruction. We are not going for the curative methods. We are looking at the patient well-being by correcting the symptom, because patient is distressful with this symptom. Now we want to manage that symptom with some medication. Okay. Yeah. The medicine here is not in order, but these are the common medication. Look at something called haloperidol. Even we have discussed about this medicine in nausea and vomiting session. And the common name usually outside the brand name is called Serinase. It is available both in injection and tablet form. And why we use this medicine? This is going to again work at chemoreceptor trigger zone in turn. It is going to control nausea. This is anti-nausea medicine. For that symptom sake we use. And what is the nursing tip when you are giving this medicine? You need to watch whether patient becomes drowsy. You need to inform the doctor because this medicine can also cause sedation. The other medicine called octreotide. Okay, this is usually in injectable form we use. If possible, we usually go with subcutaneous injectable form. Why are we giving? Why are we selecting this medicine? Reducing bowel secretions. When there is obstruction, the immediate thing in the pathophysiology, there are more accumulation of secretions and distended bowel lead to pain and vomiting, right? So with this medicine, it is going to reduce the secretions. Yeah. The other medicine, hyoscine butyryl bromide. You know this medicine with the common name, Buscogast and Buscopan karke. We all know about it. And this is also going to relieve the abdominal cramps. And at the same time, this also helps for, reducing secretions. And the other medicine, dexamethasone, the steroid, corticosteroid, glucocorticoid. Uh, this is going to, reduce the swelling and inflammation of what? In case there is obstruction, there is so much of, edema accumulation around that obstruction. When you give this adjuvant, we call it supportive medicine. When you give this injection, then the edema is reduced and then patient in turn feels some relief in the symptom. Apart from other typical medicine for symptom management, we are also going to use this medicine which is going to work on the cause for some time. Last time also I mentioned give this medicine nursing tip in the morning. If you give this in the evening or in the nights, the patient in the long run would develop insomnia, sleep disorder. And of course morphine. But we all know that morphine in turn again cause constipation. Already our patient, constipated. Then still, why are we selecting morphine? End of the day, you are not going to relieve constipation. In case our patient has severe pain, there is no other choice but morphine is going to relieve the pain. What is our goal now? Our goal is to see our patient more comfortable. That's the reason, end of the day, we even choose morphine for those patients. But how are we going to give this morphine? Which way? Any medicine I mentioned here, which way would be better? Can anyone mention based on our previous lecture? Either IV
Oral,
route, oral
orally, sir.
route, ma?
Orally, that is the best way.
Right. Can anyone, this is, may I know your name, ma? Hello?
Yes, sir.
May I know your name, ma? I couldn't see, that's the reason I'm asking. आपका
Richa,
नाम? Richa.
Richa.
Right. So I'm asking a question again. Richa mentioned, I'm sure you must have heard. Richa ji mentioned about how to give all these medicine, usually preferable way. She mentioned orally.
No,
So
sir.
I'm asked.
Sorry for the disruption. I'm saying only for the morphine.
Ah,
I'm only saying it for the morphine. The last lecture, they said that the best route to give that first, we'll
okay.
prefer the oral route for morphine. I'm
Okay.
saying it for.
Got it. Got it. Thank you. Thank you for the clarification. But in this bowel obstruction patient, now we are managing that patient symptom. So I'm just asking you all whether haloperidol or buscogas, dexamethasone or morphine, which way would be preferable for this patient, a patient with a bowel obstruction?
Maybe IV.
Yeah, there is one more way also most preferable called
Subcutaneous.
Excellent.
Subcutaneous.
Excellent. Both ways are really good. Oral you cannot give. Why? Because already patient is vomiting, there is an obstruction. And when you throw this medicine orally, patient will not be able to take. In case they take, they vomit. And then also absorption matters. There will not be a proper absorption of the medicine also. So you can go with either IV and subcutaneous route, but the best route is subcutaneous route. You can also, why? Because our patients usually, when you happen to see palliative care patients and patients in hospice, you will understand how vulnerable they are for IVs. So subcutaneous way is best. Yeah. Now, the non-pharmacological management of bowel obstruction, nursing management especially. Look at this. When a patient suffering from bowel obstruction, and we know already what are the symptoms, they have the pain, cramping pain, vomiting, nausea, constipation. All those are the symptoms. So keep those symptoms in mind. Now, how to non-pharmacologically manage that patient. So the first thing is nothing per orally, nothing by mouth. In case possible, if it is a very partial bowel obstruction, maybe you can encourage patient sips only. Otherwise, explain the family resting the bowel. That means you should not give anything to feed the patient. Why? Because it is not passing forward and it is adding more to the secretions and more to the distension and more pain, more vomiting. Mouth care. As I mentioned, when you're, keep on vomiting, how it would be usually? Typically dry sometimes, otherwise some fecal precipitates will also come from the mouth. Foul smell will be there, right? Yeah. Positioning. When a patient typically vomiting and obstructed, which position would be better? Upright or lying position to reduce the pressure. The supine position is totally not preferable. What happens in case vomiting, patient is unable to get up, they might choke. So upright position usually 45 degrees to 90 degrees patient is comfortable in case there is a fowler bed or a back rest or with the support of pillows and side rails. So we make sure patient is not falling. And also side lying position in case patient is comfortable. And monitor output, vomiting chart and abdominal grit. Abdominal grit in the sense the distension, how much you can measure that sometimes. And then how many times the patient is vomiting, how much quantity his patient is vomiting, the color of the vomiters. And emotional support end of the day is most important. Imagine someone is totally unable to take anything, unable to get up, and they're constantly vomiting. You need to be with them. Comfort hygiene, to keep a bedpan nearby because unable to reach the washroom maybe or to reach the sink. Then clean clothes. Yeah. The conservative measures. Look at this. We mentioned just now in the IV fluids. Since the patient is vomiting and dehydrated, we need to correct the dehydration and monitor for overload in frail patient. Overload in the sense, in case patient is very frail, cachectic, and then you keep on giving IV fluid, that can overload, and in turn, for the very cause you are giving IV fluid is going to disturb the patient's well-being. And also nasogastric tube, usually you call it a Ryle's tube aspiration. Have you ever tried this NG tube aspiration in your experience? Anyone? Anyone tried NG tube aspiration? Not bowel obstruction. In usually, in case you are working in very acute trauma centers, in case a patient poisoning patient also, no one. Yeah. Okay, why we are going with nasogastric tube aspiration? Because we are going to empty the contents in the stomach, and that is going to decompress the stomach. In turn, it is going to relieve vomiting. Patient need not to vomit from the mouth now. When you keep a aspiration tube and connect a, usually the, Euro bag, which is connected to the Foley catheter sometime, that bag can also be connected to this nasogastric tube, and then it is going to decompress the stomach. All the contents through the tube will be emptied into the aspiration bag. And that is going to relieve acutely vomiting and nausea and distension. Right. In case there is NG tube placed, you need to mind these things. Ensure the tube is patent. Patent in the sense you applied simple paper plaster. Imagine what happens if patient is keep on vomiting and the bag is all the times full and heavy, and there is a chance of the tube falling off. And measure, record the aspiration in the bag. Usually it is more than a liter, 2 liter bags you see. And prevent skin erosion near nose. Always there is a tube up, you see there, applied the tube, then there are erosions. So often you have to clean it and apply the new plaster. And also be alert, sudden new pain, fever or green vomiting. That means there is some perforation happened inside. Yeah, there is something else called total parenteral nourishment, TPN. Anyone heard about TPN? कभी सुना आपने TPN के बारे में दिया है कभी आपके सेटअप्स में?
Yes, sir.
Right. Why usually we go with TPN? Any idea?
सर न्यूट्रिशनल डेफिशिएंसी को पूरा करने के लिए देते हैं उसको.
Excellent. The name itself showing that total parenteral
nutrition.
So the question is now our patient is also a patient. Yeah. Fine. So our patient here with bowel obstruction, there is no nourishment, no hydration. Then patient needs some nourishment. What is the way you can go, apply either EJV or central line here. Through that, maybe we can add some protein or some other electrolytes and minerals in particular quantities. We always infuse that. So with that, patient will have some nourishment. But in palliative care setups, whether that is going to, really add some benefit to our patient or not, we need to really discuss. Look at this. This is highly selective use. Selective in the sense a patient is typically not doing well and you're not correcting the primary cause, which is bowel obstruction because of maybe some tumor or some other irreversible cause, then it is really selective whether to use or not. Maybe other patients, maybe road traffic accident or something else, some stroke patients, we are correcting their problem. Meanwhile, patient is unable to take food. उस वक्त पेशेंट को अगर नरिशमेंट दे दिया, मीनवाइल क्या हो जाएगा, पेशेंट का जो प्रॉब्लम है वो करेक्ट हो जाएगा, पेशेंट अच्छा हो जाएगा, तब ये निकाल देते हम. लेकिन हमारे जो पेशेंट को करेक्शन नहीं कर रहा है, हमने बबल ऑब्स्ट्रक्शन कैंसर की वजह से हुआ है, हम कैंसर को करेक्ट नहीं कर पा रहा है, पेशेंट का कंडीशन दिन ब दिन और बिगड़ता जा रहा है, तो उस वक्त हमने ये किया जाए तो पेशेंट का कंडीशन में उतना फर्क नहीं आएगा. इसीलिए सेलेक्टिव है ये प्रोसीजर पैलिएटिव केयर में, एब्सोल्यूट नहीं है. एंड इट इज कॉन्ट्रा इंडिकेटर अगर पेशेंट को प्रोग्नोसिस पुअर है, मल्टीपल कोमॉर्बिडिटीज है, हाई रिस्क इन्फेक्शंस है, थ्रोम्बोसिस है, तो अगर पेशेंट की लाइफ स्पैन बहुत कम है, ऐसे जो कंडीशन में टीपीएन नहीं दे सकते हैं, क्योंकि टीपीएन जिंदगी को थोड़ा प्रोलॉन्ग कर सकती है. कितना प्रोलॉन्ग कर सकती है पता नहीं, लेकिन जो भी प्रोलॉन्ग हुआ है, लाइफ ऐड हुआ है, उस लाइफ में क्वालिटी प्रोलॉन्ग नहीं हो पाएगा पेशेंट का. मतलब पेशेंट की डाइंग प्रोसेस ज्यादा हो जाएगा और सफरिंग भी ज्यादा हो जाएगा. इसे देखने में आप हमको अच्छा लगेगा, क्या है इसमें, क्या प्रॉब्लम है, पेशेंट को हम टीपीएन दे सकते हैं ना, इससे पेशेंट को नरिशमेंट आ जाएगा करके एक लाइन देखने में अच्छा महसूस हो रहा है. लेकिन वो पेशेंट को जस्टिफाई हो रहा है कि नहीं, दैट वी नीड टू थिंक। ये आप शायद हमारे एथिकल क्लास में पता चलेगा आपको ये राइट डिसीजन है कि नहीं। साइकोलॉजिकल एंड एथिकल कंसिडरेशन मैंने अभी बताया। एडवांस केयर प्लानिंग, पेशेंट का कंडीशन और पेशेंट की गोल्स और फैमिली के गोल्स को ये जो इंटरवेंशन टीपीएन जो करने जा रहे हैं हमने, वो सूट होना है। एंड ऑफ द डे हमारा गोल ये है कि पेशेंट को सिम्टम कंट्रोल करना है, हाइड्रेशन एंड डिग्निटी। You see, the end goal is focus on symptom palliation, minimizing intervention, and maintaining comfort in accordance with patient goals and stage of the disease. पेशेंट का गोल ये है कि मेरे को ट्यूब नहीं चाहिए, जो कुछ भी नहीं चाहिए करके पेशेंट और फैमिली बता रहा है। पेशेंट तो आपके पास हॉस्पिटल में आ गया, फिर भी पेशेंट बता रहे मेरे को ये नहीं चाहिए करके। आपने पेशेंट को अच्छा है करके आपको पता है, देन आपने करने जा रहे हैं पेशेंट अच्छाई के लिए। एंड अच्छाई किसको पता चलना है, कौन में होता है, उनको डिसीज कम नहीं होता है और कैंसर बढ़ता जा रहा है, डेथ भी होने की चांस है करके पेशेंट को पता है, तब पेशेंट मना कर रहा है। तो पेशेंट का डिसीजन को ऑनर करना जरूरी है। ये सब आपको पता चलेगा एथिकल क्लास में, एथिक्स की क्लास में। चलो एक पेशेंट को लेते हैं यहाँ हमारे साथ। और एक पेशेंट है यहाँ, 60 ईयर ओल्ड वुमेन है, उनको एडवांस्ड ओवेरियन कैंसर है। एंड ये पेशेंट लगभग 4 दिन से पैखाना पास नहीं की है, और पेशेंट को ज़्यादा वॉमिटिंग है और पूरा स्टमक भी ब्लड डिस्टेंशन हो गया है। ये एक पेशेंट आ गया हमारे सेटअप में। तो मैं आपसे पूछ रहा हूँ, व्हाट विल यू रिपोर्ट टू द डॉक्टर ये पेशेंट को देखते ही, और व्हाट कंफर्ट केयर कैन यू ऑफर ये पेशेंट को, और आप पेशेंट को और फैमिली को क्या एक्सप्लेन करोगे? दिस इज माय क्वेश्चन। सो आई एम नॉट आस्किंग यू टू आंसर, बट वी आर गोइंग टू डील दिस। The answer will be not very perfect and absolute. This is only to guide you. अगर एक पेशेंट आ गया तो आपको गाइडलाइंस और कैसे इस पेशेंट को एड्रेस करना करके पता रहना है। दिस आंसर विल नॉट बी द परफेक्ट आंसर। ओके, लुक एट इट। हमारा फर्स्ट क्वेश्चन क्या है? व्हाट विल यू रिपोर्ट टू द डॉक्टर? ये पेशेंट को देखते ही क्या रिपोर्ट करोगे? लुक एट दिस। नाउ यू टेल मी व्हाट एज द पेशेंट इज ऑफ। इमीडिएटली पेशेंट का उम्र कितना है? 60 ईयर ओल्ड, मेल या फीमेल? ओके, नाउ पेशेंट को एडवांस्ड ओवेरियन कैंसर। आई एम जस्ट ब्रेकिंग डाउन द हिस्ट्री हियर, द presentation. Okay, I want you all to go through this, because this is, since it is a online class, you cannot immediately mention every single thing. So I am your representative, and I am आपका जो आंसर मैं ही बता रहा हूँ। एंड ऑफ द डे हम सब डिस्कस करेंगे अगर आपको डाउट्स है तो। तो पहली चीज, पेशेंट का उम्र और जेंडर, एंड पेशेंट को क्या प्रॉब्लम है? एडवांस्ड ओवेरियन कैंसर। अगर आपने सिंपल ओवेरियन कैंसर लिख दिया, देन वी आर मिसिंग समथिंग। उनको एडवांस्ड कैंसर है वो भी लिखना जरूरी है। और क्या है? पेशेंट ने 4 दिन से मोशन पास नहीं किया है, और पेशेंट को सीवियर वॉमिटिंग है, एंड अब्डोमिनल डिस्टेंशन भी है। ये आपने देखा है, ये 4 जो चीज हमने बताया आपने देखा है, देखने के लिए मिला है। लेकिन असेसमेंट में क्या देखना है? असेसमेंट में क्या देखा आपने? एब्डोमिन डिस्टेंशन है। अगर बबल साउंड्स देखना पड़ेगा, मे बी absent, may not be absent. That is why I told you not an absolute answer. तो असेसमेंट मतलब हम चेक करना है, देखते ही ये चीज बताते ही ऊपर जो चीज है वो पता चला, लेकिन हम खुद पता चल करना है कई चीज, वो ये है एब्डोमिनल डिस्टेंशन, साथ साथ बबल साउंड है कि नहीं, और पेशेंट कैसा दिख रहा है हमको, पेशेंट डिहाइड्रेटेड है कि नहीं, कैसे डिहाइड्रेशन मतलब ड्राई लिप्स है, ड्राई माउथ है, ड्राई बॉडी है। एंड यू वुड आल्सो मेंशन हर इनटेक एंड आउटपुट स्टेटस एंड करंट वाइटल्स इफ abnormal। ये सब पता करने के बाद तब आप डॉक्टर को फोन करके बताते हैं। द सेकंड क्वेश्चन ये है कि व्हाट कंफर्ट केयर कैन यू ऑफर। लुक एट दिस। डॉक्टर, बिना डॉक्टर, मतलब डॉक्टर वहां नहीं है, आपने किसी रूरल एरिया में एक वैन में पेशेंट को देखने जा रहा है, तो आपको रिसोर्स वही बहुत कम है, तो आपके पास नॉलेज भी है, तो आप उस ग्राउंड लेवल में तुरंत क्या कर सकते हैं, पेशेंट को कैसे मदद दे सकते हैं। देखिए, पेशेंट का पोजीशन के बारे में बता सकते हैं, फैमिली को भी बता सकते हैं, क्योंकि पेशेंट को बार बार वॉमिटिंग होने की चांसेस है, और ज़्यादा वॉमिटिंग होने से क्या हो जाएगा, एस्पिरेशन हो जाएगा पेशेंट को। तो एक चीज़ तो डॉक्टर की ज़रूरत नहीं है, आप तुरंत बता सकते हैं, अपराइट पोजीशन में पेशेंट को बैठना, ये सब बिठाना। और प्रोवाइडिंग माउथ केयर, पेशेंट को एनपीओ कुछ ओरली मत देना करके फैमिली को बता सकते हैं हम, माउथ केयर कर सकते हैं। जेंटिल abdominal सपोर्ट, पेशेंट को कुछ पिल्लो का, तकिया का सपोर्ट दे सकते हैं डिस्कम्फर्ट के लिए। और फैमिली को बता सकते हैं, कभी कभार फैमिली ना उनके ऊपर पैर की वजह से बेचारा इतना उल्टी मतली हो रहा है, उतना डाउन हो रहा है करके कुछ खिलाने की बार बार कोशिश करते हैं, और पेशेंट को और एंग्जाइटी में चले जाते हैं, तो बता सकते हैं फैमिली को ये ऐसे पेशेंट को काम एनवायरनमेंट चाहिए करके, रेस्ट चाहिए पेशेंट को। रीएश्योरेंस, पेशेंट को एक वादा दे सकते हैं, एक भरोसा दिला सकते हैं, उनसे बैठ के बात करके इमोशनल सपोर्ट भी दे सकते हैं फैमिली को और पेशेंट को। और मॉनिटरिंग एंड डॉक्यूमेंटिंग सिम्टम्स, राइट। अगर ये पेशेंट को ट्यूब है, एनजी ट्यूब है, राइल्स ट्यूब है, तो आप कंफर्ट कैसे दे सकते हैं फैमिली को बताना, ट्यूब को प्रॉपरली, बैग को एम्प्टी करना। कभी कभार बैग में गैस ही आएगा, एकदम कुछ नहीं आएगा, पूरा गैस की वजह से भी वो बैग भर जाएगा, तब गैस को भी एम्प्टी करना पड़ता है। ये सब चीजें फैमिली को भी बता सकते हैं। प्रोवाइड नेजल केयर, अवॉइड सोरनेस, बार बार यहाँ स्टिकर और या प्लास्टर रहने की वजह से वहाँ जख्म भी बन सकती है, तो ये भी हम कर सकते हैं, फैमिली को बता सकते हैं। एंड देन आप फैमिली को क्या एक्सप्लेन कर सकते हैं, क्या बताना है फैमिली को। देखिए, ये बता सकते हैं, डायरेक्टली बता सकते हैं, लेकिन आपकी जो कल्चरल बैकग्राउंड की वजह हिसाब से, पेशेंट की फैमिली की नॉलेज के हिसाब से ये चेंज हो जाएगा, इसीलिए मैंने बताया ये एब्सोल्यूट नहीं है। क्या बता सकते हैं, एज हर डिसीज प्रोग्रेस, हर इंटेस्टाइन में गट ब्लॉक, दिस इज कॉमन इन एडवांस्ड कैंसर लाइक ओवेरियन कैंसर, उनको ओवेरियन कैंसर है, बिकॉज ऑफ दिस ब्लॉकेज फूड एंड गैस कैनॉट मूव प्रॉपरली, विच काजेज वॉमिटिंग एंड ब्लोटिंग। उनको बेचारे, उन लोग फैमिली को पता नहीं है क्यों उन्होंने बार बार उल्टी कर रही है, उनको पता नहीं है ना, हमको पता है, तो हम उनको समझाना है। ऐसे समझाने से क्या फायदा है, फैमिली को एक क्लैरिटी आएगा, क्लैरिटी के हिसाब से पेशेंट को केयर करते हैं उन्होंने। और क्या बता सकते हैं हम, वी आर नॉट प्लानिंग एनी सर्जरी एट दिस स्टेज बिकॉज आवर गोल इज इन पैलिएटिव केयर इज टू मेक हर कंफर्टेबल, नॉट टू क्योर। वाई, बिकॉज इट इज एन एडवांस्ड कैंसर। कम्युनिकेशन क्लास में पता चला है कि आपको ब्रेकिंग बैड न्यूज कैसे करना है, कोल्यूशन कैसे रप्चर करना, डील करना है करके, तो इसीलिए एग्जैक्टली नहीं बता सकते। अगर फैमिली के पास इंफॉर्मेशन कितना है, उनको जानकारी है कि नहीं, पता करके उसके बाद ये बता सकते हैं हम। सो वी आर गिविंग हर medications to reduce vomiting and secretions, and we may place a small tube through her nose to help remove fluid from her stomach. She is also being given fluids through the vein to keep her hydrated. ये सब बताने की बहुत जरूरत है, क्योंकि ये बताने से फैमिली को बहुत भरोसा मिलेगा, पेशेंट को भी भरोसा मिलेगा, उनका एंग्जाइटी कम हो जाएगा। हर एक बार दवा की जरूरत नहीं है। बहुत सारे बार ना पेशेंट को क्लैरिटी नहीं रहने की वजह से एंग्जाइटी में रहते हैं, यहाँ वहाँ हॉस्पिटल में घूमते रहते हैं, पैसा खर्च करते रहते हैं। और प्लीज डोंट वरी दैट शी इज नॉट ईटिंग। हमको इतना एंग्जाइटी रहते, अगर हमारे पापा या अम्मी और हमारी बच्चे लोग जो भी खाना नहीं खा रहा है ये प्रॉब्लम की वजह से बहुत डर लगता है, हमको बहुत एंग्जाइटी लगता है। अरे हमने खाना खा रहे हैं, उन्होंने नहीं खा पा रहे करके हमको मन में दुख भी रहता है। तो इसीलिए क्या करते हैं, उनके ऊपर प्यार की वजह से हम कुछ खिलाने जाते हैं उनको। लेकिन ऐसे करने से क्या हो जाएगा, उनका प्रॉब्लम और ज्यादा हो जाएगा, चिड़चिड़ापन आएगा, उन्होंने हमारे ऊपर गुस्सा करने जाएगा, उनका क्वालिटी खराब हो जाएगा। तो क्या करना, प्लीज डोंट वरी दैट शी इज नॉट ईटिंग। पेशेंट ने आपसे नहीं पूछ रही है ना मेरे को भूख लग रही करके, तो प्रॉब्लम नहीं है। एट दिस स्टेज गिविंग फूड में एक्चुअली वर्सन हर सिम्टम। We are doing everything we can keep her pain free and at ease. If you notice any symptom, please inform us. ये सब बताना बहुत जरूरी है फैमिली को और पेशेंट को भी। Right. I think as I mentioned, it is a short session. Now we are about to close it almost. So look at this. Bowel obstruction is common in advanced cancers. हमारा रोल ये है कि observation, assessment and managing and reporting and comforting and educating. Focus is on symptom control, dignity and quality of life. So red flags are sudden severe pain, green vomiting, fever, then डॉक्टर को बताना जरूरी है। As of now, nurse oriented care मैंने बताया। That's it. I'm going to end this session with this, but in case you have any questions you want to discuss, please, we have some time.
Sir, I want to see the slide related to pharmacological interventions.
Sorry, Mike, I couldn't get that.
Sir, I want to see the slide related to the pharmacological interventions, which pharmacological interventions were mentioned. I want to see that slide.
Uh, okay, a slide of pathological pathophysiology you mentioned. I couldn't get that because there is some.
The pharmacological,
Anna?
pharmacological
Okay.
intervention.
Pharmacological, sir.
Okay. I'm going back to that slide. This one?
Yes, sir.
Right.
So, sir, I want to ask, like, uh, in the last lectures, like it was said, कि for morphine, the best route is orally. But in only case, I want to know that, as you said, that subcutaneous route is for the GI. In GI, we have to include only if there is a constipation, or
Hmm.
if there is a severe nausea, vomiting, then only we have to choose the subcutaneous route. There is a severe.
Right. I got your point. See, whenever we mention here anything like, it is morphine orally is best way for whom we need to question again. Okay. Whom we are giving. अगर हमारा जो पेशेंट को ultimately ज्यादा है, not only morphine, anything they cannot take orally, right? So then we need to give injectables. So injection दे सकते हैं, लेकिन कैसे देना है, कहाँ से देना है? आईवी, अदरवाइज आईएम, अदरवाइज सबक्यू। अब आप बताइए, अगर बार बार आईएम देने जाए तो पेशेंट को बेनिफिट कम और बर्डन ज्यादा हो जाएगा ना। तो द बेस्ट रूट क्या है, आईवी है और सबक्यू है। आईवी में दे सकते हैं, लेकिन हमारा मोस्ट ऑफ द टाइम्स यू मे हैव टू लुक एट द पेशेंट वेदर देयर आईवी इज वेरी कंपैटिबल, पेटेंट, लाइक कीमोथेरेपीज की वजह से, कैकेक्सिया मजिल लास्टिंग की वजह से पेशेंट को कभी कभार आईवी उतना जल्दी नहीं मिलेगा, वेइन नहीं मिलेगा। हाँ, then अगर patient is not, you cannot find a vein but still you tried, but within hours it will, conditions, best way is subcutaneous way, because you have more space to give, and patient can, you can keep that subcutaneous line for a quite a period of time, a week, more than that also can be kept and checked. That's the reason in such what happened.
I think some technical issues, sir.
That's okay. That's okay. Hope, I think, Richa ji,
Yes, sir.
you're okay with that?
Yes, sir. Got my answer.
Sir, there is one another question. What is the location of Illam? I don't know the pronunciation. Illam.
Right.
Sorry.
It, it is very simple answer I can give you. When we go through typical gastrointestinal tract picture, you can easily locate where ileum is. Okay, the upper side where duodenum, jejunum, and then comes ileum. And then most of the patients in bowel obstruction, immediately based on the bowel obstruction, usually we go for colostomy. You know about colostomy. And then if colostomy is not possible because the obstruction is above on the colon, usually the best, usually doctor they prefer ileostomy. Next to the ileum, they'll make a induced hole and keep a bag. Through that, the contents will be collected into that bag. So to know ileum is important in that matter. Colostomy, ileostomy, where the ileum next, jejunum, duodenum, and then ileum. Yeah.
Sir, um, like maybe because of some technical issues, we can hear there
Can
is
you hear me? Huh?
there is a comment like sir आपकी आवाज नहीं आ रही है अभी भी.
Can you hear me? Hannah, you can hear me, right?
Yeah, I can hear.
Maybe for them. She didn't get the answer.
No, that is Pinky Bhatti.
Okay. Is it clear now?
I think for her only.
Okay. Anyone else?
There is one another question, sir. You said
That,
you have
uh,
four
okay, continue.
abdominal quadrant, but if
Sorry?
I am not mistaken, it has nine quadrant.
Sorry?
So there is one another question, sir. You said
Hmm.
there are four abdominal quadrant, but
Ah.
if I am not mistaken, it has nine quadrants.
True. When you divide into two halves, the upper three, middle three, and lower three. But we were discussing about particular areas I mentioned, right upper quadrant, right lower quadrant, where the, liver and gallbladder, based on the obstruction I was talking about. You are right.
So no more questions.
I think there is no more questions. So can we wind up now?
I think.
They are saying thank you, sir. Okay. So we can wind up now. Thank you, sir. Thank you to be with us. Thank you for the insightful.
Error again, I am unable.
Hello, participant. Can you hear me now? So I have uploaded that assignment's results. Please check on your email. Okay, is there anyone having any issues? Please contact with me. Sir, everyone are saying thank you, sir. So we can leave now. Thank you, sir. Thank you for your insightful session. I think you are facing some technical issues, not visible. Kamalaka, sir, can you hear me now? Sir, you're on mute. Okay.
Yeah, yeah.
We can wind up now.
Yes, yes, we can. Yeah,
Thank you, sir.
right. Right.
So, dear participants, still someone are not registered to IACA platform. So, please connect with me. Otherwise, it will be like too much for marking that attendance. So, please connect with me after the session. Thank you. You can leave now.